Okay, go ahead and get started. Good evening. My name is Amanda Rablewski, and I am the program coordinator for the Pillar program at Boulder Community Health. I would like to welcome you all to our lecture tonight on co-response and restorative justice. If you aren't familiar with me or the Pillar program at BCH, we are an outpatient program that helps connect folks to resources for substance use disorders or management of chronic pain without the use of narcotics. So there will be a little bit of contact info at the end of tonight's lecture to learn more about us or get in touch with me or our patient navigator. A little bit of housekeeping before we get started. I would like to go over the format of tonight's lecture. The lecture portion will last roughly about 35 to 40 minutes, and then we'll use the remaining time for questions from the audience. So please type your short general question into the chat box that should be to the right of your screen. And you can type in questions at any time. No need to wait until the end because we can certainly make it more of an interactive discussion as well. If there's something that comes up that you would really like to know about more in the moment than waiting till the end of the discussion. And as I said, there will be resource slides at the end of the presentation. So you can reach out to Pillar or our speakers, and there's a couple other crisis resources that will be available and accessible after the lecture as well. Second, and I know I say this when I start every single one, but thank you all so much for tuning in, either the live stream tonight or the recording. It truly means so much. Every time I see the numbers and get the feedback and the follow-up surveys, I'm so appreciative that people are supporting what we're doing here and learning about the important work that's happening in the community. And, you know, that shows that everyone has a willingness to learn. And I think this is how we fight stigma and we make safer and healthier communities. So again, thank you all so much. In light of that, because everyone's here showing their support, I also want to be transparent about what the night will hold and appropriately manage expectations of the presentation. So I always start off with what this will not be. It won't be an easy answer to anyone's individual situation. And it won't be a simple answer to the really huge issues that are mental health and, issues that come up when law enforcement gets involved or substance use or trauma. All those things clearly take a village, and we're grateful to our speakers tonight too for sharing their knowledge and expertise. So that's what it will be, an opportunity to learn more about the work being done for co-response and restorative justice and diversion. And really overall, I hope that the message is one of hope and that support is out there and recovery is possible, whatever you may be recovering from or someone you know and love is needing support with or, starting on their journey of recovery. This is hopefully a step in that direction. So all that being said, I am going to turn it over to tonight's speakers. We'll take just one more second and switch spots again. But Amanda and Elaina, I will let you all take it away. Thank you.
I'll get started as Amanda's getting situated. My name is Elaina Shively. Thank you so much for having me here tonight. I'm one of the attorneys in the Boulder District Attorney's Office, and I have the distinct honor of being able to direct our diversion and restorative justice programs. And that means I supervise the staff doing the really difficult work every day and really working one-on-one with people who are struggling and often having really challenging times themselves. And our goal is to help them get back on their feet and also support community safety. I also get to work on a lot of our office's behavioral health and equity initiatives. And so this is a passion area for me and a priority of our office. Thanks so much for having me.
And hello, my name is Amanda Rumsey, and I am one of Boulder County's co-responders. And we work and are integrated with not just the county, but several different law enforcement departments across Boulder County itself. So I will spend a little bit more time explaining exactly what a co-responder is and what we do. But I'm really excited to be here tonight and help educate all of you on what it is that we do and how we relate to and work with restorative justice.
So we're going to start by just kind of setting some of the work that we're doing both as a partnership across the county and in terms of looking how we might reform and improve the criminal justice system. So this is a map that we often use. We didn't create this. This is from SAMSHA, which is a federal agency, and we often refer to the SAMHSA sequential intercept mapping. Amanda, please don't ask me what SAMHSA stands for.
So I was just going to ask. So SAMHSA is the Substance Abuse and Mental Health Services Administration.
That sounds perfect. We refer to SAMHSA all the time, and I was afraid you might put me on the spot. Thank you for jumping in. So what we're looking at here is somewhat of a simplified map of different stages that happen in the criminal justice system. And so starting at intercept 0, that might be before anybody is even involved with the criminal justice system and often before even law enforcement is called. So how can we support people in the community so that those resources are available without having to be what we call system involved? The intercepts progress all the way through law enforcement involvement at intercept 1. We think of the district attorney's office somewhat involved at intercept 2 after the case is referred to us from law enforcement. Tonight, we're mostly going to focus on those first 3 intercepts, intercept 0, 1, and 2. That's where we're really using diversion and deflection efforts to try to get people either prevent them from entering the criminal justice system or diverted out of the system with the services and needs. I just want to mention that we are doing a lot of work at these other intercept, but that's not the focus of tonight. So we do have a number of reentry and jail-based programs, specialized probation and different treatment courts, and those would be a different topic.
So we're going to spend a little bit of time talking about co-response, and this would kind of be in that intercept 1 of the chart that Elaina just showed you. So what is the co-responder model? It's a relatively new term. However, co-response teams have actually been around for about 30 years. There's a lot of research that shows that it actually started 10 years ago in Eugene, Oregon with the CAHOOTS team model. But my team was actually at a SWAT negotiation training last week in Wisconsin and found out that Los Angeles Sheriff's Department actually started a co-responder model 30 years ago. So it's actually been around for a long time, but I feel like in the last several years, it's really starting to take shape and really starting to align with law enforcement agencies across the nation. So it's a really big, innovative, and exciting field to be in, and we're seeing a lot of positive results with what we're doing. So the co-responder model essentially incorporates law enforcement and behavioral health specialists that essentially respond together on calls. And these calls for service might be mental health related crises, behavioral health crisis, substance use, disorders. It could be a death of a loved one. It could be an aging in place person, or any kind of developmental disabilities, homelessness, things like that. So it really is a big umbrella of a lot of different things that we respond to. But essentially, law enforcement responds to a call, and if they determine that a crisis is happening, a mental health, behavioral, or substance use crisis, they dispatch co-responders out. And then our job is to help de-escalate that crisis and help connect people to resources. Our whole goal of the co-responder model is really to divert individuals from repeating those kind of types of calls or behaviors, getting them to divert from the criminal justice system as much as possible, and also reduce the amount of hospitalizations that we have. And that's essentially what we try to do. So on the next slide, we'll just kind of cover briefly that there are, like I mentioned before, there are a lot of different types of co-responder teams across the nation, and Boulder County is very well equipped with co-responder teams. So you've got the Boulder County co-responder team, and that's my team, and we are a small but mighty team. It's comprised of myself. We've got Kirsten Rigatti, who is one of our other countywide co-responders. Erie Police Department back in May actually funded to have their own co-responder, and she's integrated into our team. Her name is Melissa Richardson. We've got our team supervisor, Janine Hall, as well. So that's the Boulder County, and we service all of Boulder County unincorporated. So that can be from Lyons to Superior, Ward, Nederland, Johnstown, Niwot, Hygiene, and any kind of unincorporated part of Boulder County, even parts of Longmont count as that. We also work specifically with the Lafayette Police Department. And as mentioned before, we also have a contract with the Erie Police Department. So as I said, small but mighty team. It's amazing what we've been able to do just having the few team members that we've had. Outside of that, we also have a team in Longmont. They're called the CORE team. And I forget what that acronym stands for. I used to know it. Everyone has acronyms these days, so it's always hard to keep track of that. City of Boulder also has their own team, and that's the CERT team. And then Louisville Police Department has their own co-responder, and she's actually contracted out of Community Reach Center, but she works specifically with the city of Louisville. So as you can see, Boulder County as a whole is very well entrenched with co-response teams. I think it's something that, started very small, but because of the effectiveness and our partnerships with law enforcement, we've been able to see how well and how helpful and useful these teams are to help our first responders out on calls. So what are the benefits of co-response? I think a lot of people, there's a lot of debate out there on whether or not behavioral health specialists should be responding to, crises within the community. However, one thing we like to stress to community members is that what we do is a complete partnership with law enforcement. We couldn't be doing the work that we're doing if it weren't for our law enforcement officers and deputies that we work with, because we do go into some pretty high risk situations. So we need that safety to be there. So our law enforcement guys and gals are there to make sure that the scene is safe, that we are safe, and the community members in which we are engaging with are safe as well. So again, overall benefit of co-response is to work on decreasing arrests overall and jail admissions. We try to divert as much as possible. We will oftentimes refer to programs like restorative justice, which Elaina will talk about in a little bit later. But what we see is that if we continue to engage somebody who's in a crisis and they're just continuously getting tickets or they're getting arrested, we see ongoing recidivism with that person. And that ultimately in the long run is just going to cost the community a lot more resources and money to help that person. So our goal is to divert that, really trying to figure out what services or programs need to be implemented in order to help reduce that. Maybe the person needs some mental health treatment. Maybe they are struggling with a drug addiction and they need to be referred to the Pillar program, for example, to get help and resources to help get them back on track. So again, at that forefront, we really try to divert from law enforcement engagement and arrest and jail admissions. We also try to, again, match what appropriate treatments are needed. Not everyone is going to need the same kind of intervention or services. Some people might not need any services at all. And it's just a matter of helping them de-escalate, maybe give them some good coping skills or helping, just be a support for them in that moment. Other folks, we deal with a lot of individuals who are aging in place. I was actually on the phone today with a 92-year-old woman who, is living in her home very well, but there are some service needs there. And so we were able to kind of discuss and figure out what that might look like to help her stay functioning and independent in her 90s in her home in the mountains. But again, that's going to look different. A hoarding situation, again, we're going to maybe incorporate other services involved. So maybe it's a, in-home health nurse or getting AAA involved for that person. So really just trying to figure out what is the need and how can we help best serve that person with where they're at. The biggest thing of co-response that, you'll notice in any kind of intervention we do is we meet the client or the community member where they're at. So if they're not ready to engage in any kind of services or treatment, we're not going to force them. Our goal is to be a collaborative force with them and work with them to get them the help that they need. So sometimes they might need weekly contacts just to kind of check in and see how things are going. Sometimes they might not need that at all. So it just really depends. Our team works constantly on de-escalating situations and scene safety. And so because of that, we go through an enormous amount of training to make sure that we know how to appropriately and safely de-escalate a situation. Every single crisis is different. I've been doing crisis work for over 10 years, and every single crisis is different. There are always a million different things you have to assess for, and look out for. And so we have to make sure that we're well equipped. And so that if you make a call to law enforcement and a co-responder is coming out, that they are extremely well trained and diverse in the interventions that they use to help that community member. Another big part of what we really do and strive to do is decrease the stigma, both with mental health and with, a person's perspective of law enforcement. I mean, we'll just address the elephant in the room that there's a lot of, hard opinions about law enforcement in this day and age, and a lot of what we get through social media and what we see on the news. And it's a very fragile environment right now. And so our job as co-responders is to help the community members understand law enforcement and also understand that they're there to help them and work with them. I can't speak for any other law enforcement agency as outside the ones I work with in Boulder County, but there's not a single officer or deputy that hasn't gone above and beyond to help a community member in need. And I think we are truly, and you've worked with a lot too, but I do think that we're truly blessed to work with such amazing law enforcement officials here. So I know that it's hard because of what you see or maybe past experiences you had where things didn't go well. But I think what helps in kind of reforming that collaboration with law enforcement is the fact that they have other services and support, such as like co-responder teams, to come out and handle situations such as mental health crises. And that's just honestly something that they're not, it's not an expertise in their wheelhouse. Some are really good at it, but it doesn't mean that's something that everyone knows how to do. We also do ongoing case management as needed. So we will stay involved with a family or an individual as long as needed. It could be a daily check-in for like a week. We've had some community members we've worked with for several months. And we have some that I foresee we will stay engaged with for the rest of my career in this field, just, given the acuity of where they're at. And they're, some people just aren't willing or ready to maybe seek treatment, right? So we will stay involved as much as needed. Our job is to bridge that gap in between services. And once we get them established in whatever service or treatment that they are needing at the time, then we will back out and let those ongoing treatment providers help them with the resources that they need. So this next slide just kind of covers over the last 3 quarters. So our team was established on December 7th. That was our live go date. So we've been around for about 3 quarters, or 8 months, 9 months now. So this slide kind of goes over the highlights and all the calls that we've responded to over that time. So you can see we've had 151 behavioral health related calls. 37% of that required de-escalation services from the co-responder specifically. So not every crisis call needs to have a de-escalation intervention. And sometimes when we get there, the situation's already been de-escalated. You can see too that 43% of those calls were in unincorporated Boulder County. So again, kind of all those like little pockets and unincorporated towns of Boulder County. 15% received a behavioral health assessment. And 16% of those calls, people were enrolled into services. But the biggest number is 40% of those calls that we go to, folks are already involved in some kind of mental health related services. So you can see that, co-responder calls, again, at the top of that chart, contact type, it says, we've had about 148, 151 of those calls. 78 of those calls were referrals. So that means that a law enforcement person responded to a call, maybe it was after hours or before we were on shift, and then referred that family or that individual to the co-responder team to follow up for those ongoing case management services. And then you can also see that our third highest number is follow-up. We think follow-up is the biggest thing we can do in crisis diversion, checking in, making sure that person's okay after the crisis has kind of de-escalated, and then just, making sure, did we get their needs met? Is there anything else that came up that we can help them? So this next chart breaks down by area our co-response calls. So you can see how, for example, Boulder, and this is, again, Boulder County unincorporated, not City of Boulder, but we get our highest amount of volume of calls through there. So you can see on the bigger map that of all those calls, we've had 148 calls alone just from Boulder County Sheriff's Department. So it's huge. Second on that list is our Lafayette PD. We get a lot of calls and case management referrals from them as well. Third is Erie. And I think a lot of our increase in call volume from Erie, if you kind of look at that chart, it was a little low in the beginning and then it spiked up. That's because we hired our amazing co-responder, Melissa, who's been embedded in that police department and works with them hand in hand. And then the rest of the areas are kind of, again, lower, but they do use us. Netherland uses us. We get called out to Superior all the time, things like that. So just kind of breaks that down just a little bit. The only other thing I wanted to touch base that I forgot to mention a little bit earlier is the different types of co-responder programs specifically. There's primary and there's secondary. And my Boulder County co-responder team works on a secondary model. So this basically means that law enforcement goes out first to that call, and then they make that decision whether or not they dispatch co-responders out to the scene. A primary model, which is something that City of Longmont operates on, they are primary, meaning dispatch makes the determination on whether or not the core team responds to a specific call or law enforcement goes. So they arrive on call, and their teams are comprised a little bit differently. Their co-responder, they have pods, and it usually consists of a patrol officer, a paramedic, and a mental health clinician. So they'll go and take those calls on a primary basis. So those are kind of the differences. And if you guys have any questions, please feel free to ask, because I know it's a new kind of evolving world and there's a lot of differences, and not every co-responder model looks the same. And we're all just kind of, figuring it out as we go, but really trying to collaborate with our partners to figure out the best way to serve Boulder County.
All right. Well, great overview on that. I'm going to shift gears a little bit to some of the later intercepts, but I wanted to just talk a little bit about that important part about partnership and collaboration. And the way that we are lucky, I think, also in Boulder County is that we have all of our law enforcement partners and a number of community agencies at the table discussing how we can better meet people's needs in the community without necessarily having to have them come into the criminal justice system. And so that Intercept 1 really is trying to focus on how can we meet their needs without them entering our system. And those would be cases that the DA's office would never see. And then we also have the cases that we do get. And that means that law enforcement made contact with somebody, determined that a crime had occurred, and referred the case on for prosecution to our office. We still have a lot of our own discretion in how we handle cases from there. And so it's really important that we have partners that we can work across the system so that we have different, what we would call off-ramps or different specialized programs, so that we are not processing all cases the same. And one piece that Amanda talked about that's really important is equipping people with new tools. And so some of the criticisms of the criminal justice system are really fair in that we haven't had the right tools to be able to respond to the needs that our communities have presented. And some of those really are around substance and mental health, other behavioral health challenges. And unfortunately, often those calls result in health case being entwined with the criminal justice system. So a lot of our work is trying to figure out, where does it make sense to use a public health model and try to really have people return to the community or get their services met through the community? And where do we really need to use more of the criminal justice safety model around trying to figure out what is a community safety risk and what is really more of a need for services in the community? So when cases come to our office and we review them for diversion, what we're talking about is more of an alternative to our traditional prosecution methods. And so in lieu of going through the criminal justice system through and through, so that could be a plea bargain or a trial that results in sentencing, we off-ramp those cases by offering an alternative. And this is an accountability program, so people do need to be owning up for their offense. And we're going to support them in that accountability, because taking accountability can be a process and it's a learned skill in many cases. We support them in repair of harm. So that means that we're giving victims voice and choice and input into what they want to see happen and what they need to have their needs met, as well as supporting the person who's offended in how they can also help repair harm. And that really helps to reintegrate people back into the community. This combination of both trying to address risk and underlying needs with that accountability and repair of harm is what we see is really effective in helping people not offend in the future and help to get them in a better place. And so that's why we talk about it as a public safety program, because it really helps to improve outcomes for everyone involved. I'd hope that we can all agree to some extent that not all cases are appropriate for diversion. And so when we're talking about diversion, I want to be clear that we're not only talking about the lowest level offenses that we might see. We might see some pretty higher level offenses or some moderate or moderate risk. And we're definitely going to see some higher need folks. But we're not talking about all cases that come through, but we are hoping that we are working as a system, and we are with our partners, to try and improve all of our processes and service provision across the board. This is just a brief slide that I'll touch on, that we have expanded dramatically since 2014. Boulder County has had a rich history of juvenile diversion for decades. And in 2014, we were part of a state pilot program that looked at expanding juvenile diversion and incorporating restorative justice practices. We were lucky to receive that a grant, essentially, to get us started. And in 2016, after doing a lot of model work, we incorporated a full in-house restorative justice program. We also expanded at that time to young adult diversion, largely because of the needs around behavioral health and the college community here. That was also a pilot program that we then expanded into all ages. We have both juvenile and adult diversion programs. We have pre and post filing, which means sometimes we divert cases prior to our office even filing the charges. We're often collaborating with Amanda's team to see how we can best support people. We also have post-filing, which means if our office does file the charges, or in misdemeanors, law enforcement files the charges with the court, that we can divert from there. But these would all be pre-conviction, so people don't have this collateral or ancillary consequences that might come with a criminal conviction. In 2018, we really focused and collaborated on starting and trying to launch these co-responder programs. Some of them are still in their first years, but we're definitely building on with being able to track the data and see the success. We're building off of that. And as Amanda talked about the primary and secondary teams, we're hoping to learn from that. And so where we are now is not where we intend to be. We're working on a behavioral health community hub and increased capacity, and increasing our team's knowledge of harm reduction kind of across the board. And what that means to us is understanding that people's journeys don't all look the same, and that public safety might be best met by understanding that sometimes abstinence isn't the first treatment goal, and that we need to look at things in more of a holistic sense of how can we help people get their criminogenic risks met, their personal needs met, what are their goals, how can we best help people get onto their next step without some of those more what we would call like standardized terms and conditions. So diversion's not like a miniature probation or one size fits all. It's really trying to use some of those public health and harm reduction frameworks. And
Elaina, we've got so a question came in about the diversion and the expansion, and I just want to make sure for the person that asked it, that's in the audience that's listening, let us know if this answers your question. But I think you kind of did already with the expansion of. So their question is, does the process include community-based behavioral or substance use care? If not, could it? And it sounds like that's been the focus for the last couple years. And as, you know, the co-responder teams grow, that will become more and more just part of the fold of the diversion programming.
Yeah, the idea is that we're moving earlier and earlier upstream so that people's needs are being met before it ends up in either those crisis calls. I mean, we're all trying to respond to them, but we're trying to be more proactive and preventative than always reactive. And so, yes, we're definitely trying to attack it from all sides. There's a great quote from a law enforcement officer that we surveyed once who said, diversion programs are only as great as the programs we can refer people to. And so we're still dealing with some of the gaps in the community that I think we all see. And so in a lot of senses, we're also service navigating and we're making connections. And so we're trying to build those so that they exist outside of and before our system, as well as using them once the case does come to our office.
So I think you actually just answered the follow-up question too,
Okay.
but let me make sure. So it's asking, does the process include social prescribing? For example, if people are people moved from a criminal process to a restorative support in developing social networks, and what are the gaps? And it sounds like that's what you're trying to address, though, with building community relationships, is that social prescribing of getting folks connected.
Yeah, I'm going to jump ahead a couple slides to answer some of this question. So we really look at because we're system involved, we have to be careful about what it is that we require versus what it is that we support. And so when we're talking about requirements, we really want to look at harm repair in terms of meeting the needs of the person who the crime impacted. And that's going to include the offender themselves, but also the victim, the community, and other impacted parties. When we're talking about risk and need and responsivity and how do we help the person reduce their risk of coming back into the system, we're really talking about those underlying issues. So how do we target our interventions to help? And so in that case, we're not doing in-house counseling. We are purposefully referring out to community agencies so that those supports can outlast the period of diversion. Our average completion in our program, which means the system involved or the system entwined time, is about 4 months. And that doesn't mean that those people's journeys are over. We want them to be able to have those community supports that last longer than diversion. Sometimes we're just helping them know where those supports are because they're not ready for those treatment interventions or modalities at that time. And often we are connecting them with different supportive communities. So one piece that we're always looking for on diversion is that they have some kind of pro-social community. So we always talk to people and, again, talk about something that's not one size fits all. For some people, that's their gym. For some people, it's some kind of sobriety group. We work a lot or know a lot of folks who are doing sober activities in the community. We use a lot of the same programs. We refer to pillars sometimes.
We appreciate it.
Natural Highs is another wonderful organization that is huge, especially with our young folks. And so we are trying to look at ways that we can enhance and support their chances of staying on their positive paths or building that motivation and support to change if that's what's needed.
Great. And it sounds like, Amanda, too, if I'm understanding correctly, that's also what your team is doing, is trying to get people connected to those networks so they're not isolating and they can reach out in different directions so it doesn't, like you're saying, get to the point where they're calling again or they're, calling 911 or, going to those more kind of extreme
Yeah,
ranks.
absolutely. And I think a lot of it is really just providing that education. I think a lot of us like to think we know what resources are available out there, but I mean, even I've been working with the county for a long time and I'm still continuously learning different resources that are available. So,
Absolutely.
it's there's a whole world out there. And so sometimes we just need to ask for help. And even if you don't ask for help and you end up calling law enforcement and we show up, we'll offer that help to you. Our whole goal is to really connect people to those resources that might be helpful to them. Again, if they're a willing participant, as far as when we step in.
Yeah. Great. Thank you both.
Yeah, those are great questions. And I think one piece I would also touch on is that we really strive to have equitable and accessible and culturally responsive programs as well. And a big piece of this is also being trauma informed. And so when we talk about modalities, when we're trying to match to services in the community, talk therapy is not going to be for everyone. Equine therapy is a really incredible program. It's not for everyone. And so trying to really meet people where they are and meet the needs of the community so that we are effectively using new tools or newer tools in the system to drive down those risk factors. What we see is that it helps to improve the outcomes for everybody involved. And I'm going to jump to talking about restorative justice as one of our most important interventions that we use. I'm going to just briefly touch on what restorative justice is. I need to acknowledge that restorative justice is nothing new. It's been used for thousands and thousands of years, mostly in indigenous populations. And using it involved in the criminal justice system or with system work is relatively new, more from about the 1970s. We call it the 5 R's in restorative justice: relationship, respect, responsibility, repair, and reintegration. And all of those are equally important. And we use restorative practices throughout diversion, whether or not we do a full and formal restorative justice process. But what it basically does is, if we think about some of the missteps we might have all made as teenagers, I certainly made them myself, and think about people that I harmed with my actions, and kind of opening up that very challenging, but an opportunity for me to sit down face to face with the person I harmed to talk about what happened, what I was taking responsibility for, and what steps I might be willing to take to repair harm. That's kind of the central to this. And for us, we're always wanting to work and focus on victim-centeredness and community safety as well. So if we think on a little bit of a wider scale about also being responsive to what does the person who was harmed need, sometimes what we hear is, I just want to ask questions. Sometimes the adversarial system isn't best set up to have those types of questions answered. And so for some of these cases, we're able to carefully facilitate those sit downs where there's a lot of preparation. It's voluntary for all parties. There are support people involved, neutral facilitators who are highly trained, community members involved. We can help to have that sit down. So it might be you were highly intoxicated and you entered my house. You might have thought it was your friend's house. It was my house. It was so incredibly terrifying for my family to not know who you were and that you entered our home space. I really want to know why our house, or what did you touch while you were in the house, and those types of things. And then to humanize and see for both of those people, who they are, and that they're more than that one night or that one action, and that they're willing to take steps to try to repair that harm. We actually survey everybody who comes through our restorative processes, whether it's the offender who's referred because they've committed a crime, or the victim, or the community members. We often have law enforcement who want to sit in these processes as well. And it really helps for all the parties to hear, hey, I was taken off of X number of calls because I was responding to this situation, and I was really scared for you. Those types of humanizing pieces as well. And often the parties will agree to a contract of sorts, or an agreement of what steps need to be taken, and that will become a part of the diversion that the diversion coordinators will also support. As I mentioned before I went on a slight tangent, we do survey everybody, and we're always really excited to hear that we have 99% satisfaction rates that get
Wow.
returned from our victims and from community members. And one of the biggest pieces to me also is that 95% of the offenders who come through our program also say that they were satisfied with the restorative practices that we used with diversion. They feel like their cases were handled fairly. And that sense of procedural justice also helps support community safety, because when people feel like the system worked well and treated them fairly, then they're more likely to buy in and engage in the other services that we're trying to put in place. So I keep flying through my slides, but I do want to highlight this one, that this combination of using risk and need assessments, trying to match people to the services and supports, interventions, treatment modalities, communities, pro-social activities, all of those, that combination of those sort of two arms show us an 8% recidivism rate, which means that only 8% of the cases that we complete reoffend. And we're tracking at 1 year, 3 year, 5 years. We continue to track and update that number. And depending on the program, 94 to 97% of those who start diversion complete successfully, which means they're never convicted of a crime. The case is dismissed and it's off their records per se. And they're also matched with all of these different services. It's another place where our office also gets to involve the community. We have about 40 active volunteers who are incredible, and it helps to improve the system outcomes as well as future system savings, which is similar to the co-response program as well. One other piece I wanted to highlight, because I think it's important to note, is that when I talked about using more of a public health or harm reduction approach, some of the things that we're tracking is drug possession charges, and we do have a specific diversion program for drug possession charges. And when I talk about drug possession charges, I'm talking about cases that the sole charge is using or possessing a illicit substance. And we did see a major change in legislation in 2020, where many of the drug possession cases that were felonies in 2019 and prior years became misdemeanors, which is a lower level offense in 2020. So I went ahead and combined those numbers in these two charges, but I did want to mention that defelonization, and that's something that our office did support. And so for most what we would call simple possession cases, they've now become misdemeanors when they used to be felony charges. We were diverting them as felony charges for the most part, but now we're diverting them as misdemeanor charges. I wanted to show the decrease, and I think that this is something that we're going to continue to watch with trends. In 2019, we were close to 250 cases that our office charged. This doesn't show whether or not we diverted them, but these are cases that came through our office. And in 2020, granted that the pandemic has changed everything for all of us, we were at less than half, and we're only a quarter into 2021 when I pulled this data, but we were on track to continue to see a decrease in those cases. What this shows to me is that some of our efforts in moving the needle up front, such as co-responders or encouraging law enforcement not to arrest and take to the jail because of the COVID outbreaks, etc., we're seeing fewer cases come to our office for simple drug possession. When they do come to us, we still have the opportunity to divert. We're sending folks through a process called SBIRT, which is screening, brief intervention, and referral to treatment. And again, that's going to be harm reduction and public safety based. It's going to be individualized. And that's what we're asking, so that they're coordinated with some kind of behavioral health treatment provider, but we're not mandating any special level of care for those cases. And these are the types of trends that we're going to continue to track as we're preventing some cases from being involved in the system, as well as responding to those that are in our system. It also helps us support equity, since our jurisdiction at the Boulder DA's office is all of Boulder County. It's the 20th Judicial District. So some municipalities might have their own internal police department diversion programs. Now we see everybody has a co-responder program, but for a while they were kind of blossoming or starting at slightly different times. This gives us an opportunity to somewhat level set so that anyone who is charged with a possession crime still has that opportunity for a review of a diversion. Okay, Amanda, before I check time, did we have any other questions come in?
Not so far. I mean, I have a couple. Yeah, so we've got about 15 or so. Sorry. I should talk into the mic so everyone can hear me. I apologize. No, so I certainly have a couple questions. We have not had any more come through the chat right now. We've got about 15 or so minutes left. So if you all have a few more slides, and then we can wrap up the presentation and open it up for some more questions or thoughts. That'd be perfect. We have a great amount of time for that.
Okay, why don't you shoot with your questions, Amanda?
So, when I took notes because I didn't want to forget. One of them was how, when you, Amanda, when you mentioned that hold on one second, that you're diverting from jail and the hospital, how are you doing that if it's like a severe mental health related call?
Well, I think it really depends. It's a great question because it really depends on the type of call. I wish I could say we always divert from the hospital and jail, but unfortunately, sometimes that's not the case. So when we do come on scene, we typically will do any kind of mental health assessments. So that might be like a suicide risk assessment. That could be like a biopsychosocial assessment. And really our goal is to figure out, one, what the crisis is. What does their normal look like? Is this typical behavior, or is this something that's, a little bit unusual for them that day? But we have to make sure that they are safe. We get a lot of calls for suicidality. So it's really trying to determine, is, the individual experiencing, or exhibiting self-harming behaviors, or are they, kind of, it's a gray area, but are they cross that threshold where they are suicidal and they have a plan and they have the means to that plan, and without any other intervention, if we were to leave, if we felt that they still would be at risk of harming themselves or harming other people, that homicidal ideation, then it's our job and liability to place them on what's called an M1 or 72-hour hold and transport them to the hospital for that ongoing care. So not always can we divert, but we do the best that we can. And in a lot of those situations too, we will follow up with that person. And I've gone to the hospital several times with the community member that I was working with to, one, make sure that I provide the emergency hospital staff with adequate information about what's been going on, and then also provide that collaborative care piece. A lot of people we come in contact with might not have services in place, and sometimes when they leave the hospital, there might not be any services in place. So it'll be my job then to kind of follow them and make sure that they're safe, that we don't have this situation arise again, that they know that they can call me or my team for support and for help, and again, kind of bridge that gap. We've had some situations where we've worked with community members for a long time and have had to issue even our own court-ordered M1 pickups, which is a totally different topic. But, so sometimes it gets difficult because we have to make that call in order to ensure like safety of the community and that individual. So it just kind of really depends, but we will do everything we can to divert that from happening. And I will say, like, especially with adolescents and youth, like, I'm very sensitive to what their experience might be in a hospital setting or going to jail. So, as long as they've got adequate family support in the home and things like that, I'll do what I can to kind of safety plan at home with everyone involved, as opposed to, sending them to the hospital, because that can be a very traumatic experience if they're young and they haven't been through something like that before. And, sometimes it's not always the most helpful. So, our goal is to intervene in the most beneficial way that we can for that person.
That's wonderful. And I again, like that trauma-informed piece that you were talking about, Elaina, taking into consideration what a hospital stay might do to, like a 14-year-old kid. Or,
absolutely, yeah.
And just out of curiosity, is it just like the closest hospital or one, like, because for BCH, for example, we have our inpatient mental health unit. So is it generally like, okay, we know we're taking them right to BCH, or is it just the closest hospital like in the vicinity?
So generally speaking, it will be the closest hospital, but this is really up to dispatch and law enforcement or paramedics, whoever is transporting that individual to that hospital. So they'll contact dispatch, and dispatch will let them know if the hospital is accepting or has room for inpatient beds. And if they don't, they will divert. So if we are in or around like the Boulder area, yes, typically we will go to Boulder Community Hospital. Sometimes we're on divert and we have to go up to Longmont to drop that individual off. We also utilize Good Samaritan Hospital in Lafayette quite a lot, and then also Avista Hospital in Louisville. So it really kind of depends. Short answer to that is yes, we try to go to the closest hospital possible, but it's not always the case.
Sure. Great. Thank you. And then Elaina, one that I had when you had started talking about, just what diversion and restorative justice looks like, and the accountability piece is so big for the person that's committed the offense. But how are you all supporting that accountability piece if they want to engage in your programming?
Yeah, that's a really great question. I talked about being trauma-informed and equitable and accessible. And so I think some of that is understanding that accountability looks and sounds differently out of the gate for everybody. And so you might have had a parent who's really taught you how to make a good apology, and you might feel comfortable, or you might not have those skills out of the gate. And so we want to talk to people. So we're always asking, what can you take responsibility for? What steps did you take that went wrong? Or where did you go astray here? Or what have you thought about that might have gone better? Or what would you do differently? And so those types of conversations can help people understand. And then we're also building empathy. That's a really important skill in terms of reducing both criminogenic risk and behavioral health, different risks to supporting our community. And so sometimes people really are impacted when they hear how much their actions affected somebody else. And so sometimes it can be as simple as, imagine if it wasn't this classmate you'd been arguing with all this time, but it was your little sister who was in that situation, and helping people kind of take themselves out of it. Or I use a lot of examples with the young people, but what is it that you hope that your younger siblings would learn from you as their role model? Or trying to find those places. We use what's called motivational interviewing.
Wonderful.
Yeah, we love that.
So it's a technique that's really conversational, but it really builds on their own strengths. And so we're not going to assign anything that is standard, like you must do 24 hours of community service for X type of crime, because people might have already worked really hard to repair harm before they even make it to us. Sometimes the system is slow, and people have already taken substantial steps. So we want to take that into consideration. Sometimes we'll build off of an opportunity. Somebody who, for example, we're sitting in this amazing cottage right now. Somebody tells us that they're really, really interested in music, and that's what they want to do. And we know that we have a volunteer who is a music producer. We might see if that person might be willing to participate in the process, and maybe see if we can help offer them to do community service if the other person would consent to that, so that it might help build on their skills as well as help to repair some of those community harms. So I hope that answers your question. But we're trying to do it in a really supportive way where we're saying, hey, we get it that people make mistakes, that those harms and impacts can be really huge and scaring and traumatizing to others. But you are also more than this mistake. And how do we help you understand that as well? So it's a lot of repair to self as well.
Yeah, that definitely answers the question. And I think it truly speaks to what both of you are talking about in trying to give tools and this, engage critical thinking and looking beyond their situation or just themselves. And it would be so fascinating to, we know, right? Like when people do get involved in like the criminal justice system for that one mistake, the trajectories can be so different than if they could have just had that opportunity to make the amends and do the repair. Definitely answers my questions. Thank you both.
We also have different levels of diversion that I would just mention. And so when I talk about a lot of these resources, this would be they're also intensive for our office to provide these diversion programs. To be honest, the least expensive or the easiest thing we could probably do is plead a case and have that person be on their way to probation. And I would say we have we share a lot of goals with probation. Probation is also moving towards more individualized case management and public health models and using more harm reduction practices. But what I would say is that, part of our job too is really trying to assess, is this person a risk to the community? Is this person somebody who we think is going to reoffend? And is there any evidence for that? So is it, not only based on our own biases or what we think? Because sometimes that's not tied, research shows us it's not always tied to the offense. So we kind of have to keep that criminogenic risk separate from the risk from the offense that we have in front of us. And so that's where we really think about the harm from the impact. So the level of harm caused, the severity of the charge or the crime, and then the person's propensity for public safety or recommission of crime. And then how much are they willing to engage with us and on what? And so that doesn't mean we can target or require them to address everything that might be a challenge for them in their life, but where can we kind of dig where the dirt is soft to get the best kind of bang for our buck in terms of helping them get on that trajectory that's more positive.
Yeah, that's a lot of moving pieces. Intensive is the word.
Yes.
But it's, and I agree. We had a comment come through the chat that this process is so humanizing, both of what both of you are doing. And like I said, I agree 110% because that's what's missing a lot of the time is that human aspect and just looking at a diagnosis or a charge
Right.
or, whatever it may be on paper. So it's for those of us that also work in the field, it's appreciated. And
it's a big
supportive.
piece, and
Yeah.
it's very important to both of our offices and our partners.
Absolutely.
And a lot of it is training. We've done a lot to talk about how can we use our language to be more inclusive within the system and less stigmatizing.
Yeah.
And when we're thinking through different processes or that SAMSHA map, most people that come into contact with our system are going to come back into our community. Many of them are never going to leave our community because they will not be arrested and they're going to be on community supervision or diversion or deflected through Amanda's program. Very, very few people are we going to incarcerate that they are not coming back. So even those who are incarcerated, Colorado has one of the lowest or worst rates of what we would call, I don't know how to say this. This is like a triple negative. We have one of the highest rates of recidivism of people coming out of the Department of Corrections. And so working there to try to figure out how do we kind of embrace the fact that people who are coming through our system are still such an important part of our community and are not just that one act,
Right.
it helps keep us all safer.
Yeah, absolutely. Wonderful. Perfect. Thank you both so much. So we've just got about 2 more minutes. I think if we just want to maybe put up the resource slides and just tell folks how to get in touch with either, you all directly or your offices or your, someone on your team if they've got questions or are looking for support and more information. And then if there's any other questions, like I said, just about 1 or 2 more minutes left in the hour here, so we could answer something quickly. But if not, while the resource slides are up, and I'll give that just a second. Do you know of other jurisdictions in the state that have this model? Also, does the probation department help with diversion?
Yes. Well, so we have 22 different jurisdictions in Colorado. Most DA's offices have some sort of diversion program, and there are many different co-response programs kind of building all over the state. You have to remember, many of our jurisdictions have multiple counties within their jurisdiction, and then we also, we have 10 different law enforcement agencies that we work with. So it's kind of spread across the state, but there are a lot of great diversion programs. I will say that we're really proud of our program, and we train nationally on our programs, so we're helping to implement similar programs in district attorneys' offices or community-based programs. As often, we share resources as often as we're asked for them. As far as probation, they're a key partner to us because they're another place in the system where we're all trying to improve outcomes and humanize, improve public safety, victim voice and choice, as well as really meeting the actual needs and underlying needs and risks of the folks who are in the system. And so they're not diverting, but they're an important and key partner that we collaborate pretty closely with.
Perfect. And just very specifically, is there one in Weld County? And this is awesome. You all rock.
I appreciate that. Weld County does have a diversion program in their DA's office. I don't know if you can speak to their co-response.
Yeah, they also are very well inundated with co-responder teams, both in Greeley proper and throughout Weld County.
Right on. Yep, I agree. This is amazing work. It was such a treat to learn more about it from the both of you. Thank you so much. Just a couple more parting thoughts. Thank you everybody too who tuned in tonight, and for those of you watching the recording later. So a recording of tonight's lecture will be available at bch.org/substance abuse, or if that's not the right link, I apologize. You could go to bch.org/pillar, PILLAR, and it will be at the top of our webpage in our video library. There will also be a post-lecture survey going out to those of you that registered tonight. In about a week or so, you'll be getting an email. Please take just 1 minute to fill that survey out. It really helps. It helps us, as we're grant funded, so we look for the feedback, and it really helps to inform future lectures. Tell me what you want to know about, and we can hopefully get that education out to the community. And also too, for those that are watching the recording, if you're in the video library, you will be able to find a link to that follow-up survey as well after the fact. So, any other questions, please feel free to reach out to me. I'm happy to bounce questions or inquiries or anything to our speakers tonight. And thanks to Stone Cottage, as always, for helping us get the word out, and hope you all have a fabulous evening.
Thanks so much.
Thank you.